The last thing I need to hear about our CJ. Yeah.
Hello, can everybody hear me? Hi. I have a few notes I wanted to say before I introduce our next speaker. One note is that Becky Sansbury's talk later will be about self-care, not about massage. The title is a little bit ambiguous, so there was some confusion on that. And also, before I introduce our speaker, I'd like to take this time to note that if you're new to a diagnosis for yourself or your child, we have a special roundtable session just for you in our breakout room. Please join metabolic dietitian Summer Gahan and genetic counselor Lehan Sremba for their roundtable discussion titled Navigating a New Diagnosis. This will be a great space for you to share your new experiences with other families, take some time to digest all of the information, and of course, ask questions. And again, this special roundtable is happening now in the breakout room. If you're staying with us for our main session, we are so excited to have Dr. Georgianne Arnold discuss the teen years. Last year, she did such a brilliant job at sharing on this topic that we wanted to bring her back again this year and give her another opportunity to share her thoughts and experience on the subject. Just as a reminder, this year we have formatted our FAODS through the ages sessions so that there's ample time for the presentations and also question and answer periods afterwards. So as we get to the Q&A at the end of the presentation, if there's a question that is asked and you would like to share a personal experience that relates, please do not hesitate to raise your hand to share. Without further ado, I would like to introduce Dr. Georgianne Arnold. Dr. Arnold graduated from Indiana University with degrees in both biology and chemistry. She has a master's degree in medical genetics from Indiana Purdue University and at Indianapolis, and graduated from medical school at Upstate Medical Center in New York. She completed a residency in pediatrics at Northwestern University and a fellowship on genetics at the University of Colorado. Dr. Arnold is board certified in pediatrics, clinical genetics, and clinical biochemical genetics. Previously, Dr. Arnold was faculty at the University of Arkansas and the University of Rochester. She is now professor of pediatrics and clinical research director at the University of Pittsburgh Medical Center. Her main interest is clinical research in inborn errors of metabolism. She is currently conducting numerous clinical trials for a variety of metabolic disorders, and is the longitudinal project principal investigator for the National Rare Disease Consortium for Phenylketonuria. Dr. Arnold has authored more than 70 medical publications, received the Shapiro Award, and has presented papers at numerous national and international meetings, and is currently the president of the Society for Inherited Metabolic Disorders. Thank you, Dr. Arnold, for joining us today. Your willingness to guide us, listen, and always engage us in such insightful conversations.
Well, I guess I have to update my bio. I'm the former president of the Metabolic Society. Okay, so let's talk about adolescence. Adolescence is the conjugator of childhood and adulthood. It's in some ways a first world problem because I don't know if you ever read a Jane Austen novel, but you know, the boys were sent off into the Navy at age 12. We went into the factories before child labor laws. So it's a relatively new thing. Now, what's interesting is that at this point, the kids are usually standing with one foot in childhood and one foot in adulthood. And they switch back and forth, which one they're standing on so fast that your head spins. As parents, this can be very frustrating. Sometimes people don't even know where to go. They just want to throw up their hands with their teenagers. But that's okay. We're gonna talk about some of that. So don't look back. We're not going that way. So this column is attributed to an Ann Landers column that was in the paper, I don't know, 25 years ago. But I don't believe it's original to her. But it just talks about how your mind changes as you go through life. So, you know, when you're a baby, my daddy can do anything. And then, yeah, really? And like, yeah. And then eventually, maybe I should ask dad. And till I wish I could ask Dad. So, it's a mindset that you go through as you go through life. And it's normal. So, this is what you're in store for. And the first time I saw my niece do this, I had to stuff my fist in my mouth not to laugh. But then it becomes this and this. And it's not so funny anymore. So let's talk about what's going on in an adolescent's head. Because I don't know about you, but I don't really remember. So adolescents are going through a lot. You may think they're just lying in bed, sleeping late on Saturday mornings, but there's a lot going on in there. And they have to develop comfort and with a new body. And they have to develop an independent identity that's separate from their parents and their own belief and value systems, which can be quite taxing to parents if they decide it's different from yours. But most kids, in the end, they may stray out onto limbs, but they typically don't end up all that far from home in terms of value systems. They have to grow their social and academic skills, algebra, chemistry, biology. They have to learn how to get along with their peers. They have to prepare for adulthood, and they have to develop impulse control and maturity. So there's a lot going on in there. What are some of the problems? Teenagers think they're omnipotent. They don't think anything bad is ever going to happen to them. When I was in high school, the fun thing that guys did on Friday night was get some beer and then drive down the steepest hill in town without headlights on in the car. They thought that was fun. So, you will see risk taking that you wonder, how could they not realize that this is dangerous? There's also this craving for autonomy, but at the same time, this craving for security. Like I'm going to do this myself. And then they get in over their head and they don't want to come to you and say, I screwed up, I got in over my head. Sometimes there's other people they can go to. Sometimes you have to intervene. And there's a real reluctance to admit that they're not ready to do it yet. So, this is the hard part. Getting all that in there with everything else that's going on. One of the main issues in adolescence is fitting into your peer group. Where do you belong? So if you look, young people are experiencing a heightened arousal in the brain, and they're very sensitive to social acceptance and rejection. A lot of that's body image. And now we have patients who may have feeding tubes. They may consume formulas, and if they take it in front of other kids, maybe they look funny or smell funny. They may miss out on important things. They may not be able to go to a field trip that is going to be very physical, or they may miss it because they're having a rhabdo. And so having a chronic medical condition is really anathema to helping kids fit in. So that's something you have to really keep in mind. And then brain growth. They used to think your brain was done growing and developing by the time you were 6. Matter of fact, in kids with phenylketonuria, PKU, they used to stop their diet at age 6 because they thought, well, nothing bad will happen now. We now know that that's not true, that adolescence technically ends around 26. So you have adulthood legally, but you're not always there emotionally yet. Females tend to mature a little earlier than males. And in fact, if you look at most marriages, kind of on average, women marry men who are about 2 years older than them, because that's kind of more where their maturity levels match. But adult brains learn differently. So if you put somebody in a functional MRI scanner and teach them something new, if you take a kid versus an adult, different parts of the brain will light up. And this is one reason why a lot of people are much more successful when they go back to school as adults. And they're like, why couldn't I do this when I was in high school? Well, you were wired differently in high school. So don't even give up if school's not going that well for you, because it might get better. And of course, adolescents are much more receptive to reward-based than punishment-based, but that's not always easy as parents. So how are we doing so far helping young adults and teens transition into adulthood medically? Well, there was a paper out last year that, I went too far, that looked at metabolic disorders, and most of that care is still happening in pediatric hospitals. I know at Pitt, we can admit anybody up to 26, and after that, we have to get permission. And if you show up 40, dead drunk, they're probably not going to give me permission. But there really are not a lot of adult physicians. If you have one, you're lucky. So the interest in healthcare transition is kind of robust everywhere, but we really don't have a lot of standardization on how to make it happen. And the other thing is in pediatrics, we tend to do a lot of hand-holding. We tend to spend a lot of time on the phone with our patients. We spend a lot more time in clinic. Adult providers are like now being pushed to see 12 patients an hour. That's 6 minutes. And so you can see that that's a tough transition. And I learned about that when my mother became ill at the end of her life. And I would have to call and talk to a physician, and nobody cared. It was really difficult. So the European system actually seems to have more metabolic trained providers, but they still don't have enough. So someone in the federal government developed this resource center called Got Transition. Now, this was actually initially intended for kids in the foster care system. So it pushes them pretty quickly into healthcare independence. I'm not sure that all of us would be really comfortable pushing kids as quickly as they want. But they talk about transitioning youth into the adult healthcare, transitioning to an adult approach, even if you stay in with a pediatric provider, and then integrating young adults into the adult healthcare system. And there's 6 cores that they break down in there. So transition and policy, tracking and monitoring, readiness, planning, transfer of care, and then completion. They publish a toolkit for families and for providers. So you might be a little surprised by some of this. I was. And they said they're starting at age 12 or 13. Start asking what will happen if they no longer care for young adults. Most people are not really thinking about that by 12. And I might be a little early. But by 14 or 15, carry your own health insurance card. Well, I can tell you, I would say a copy of your health insurance card, because when I was 14, I would have lost it in 5 minutes. But these are things that you can do. Practice making, getting your refills, and then to start to see the doctor alone for at least part of the visit. And this one's hard for parents. It's often hard for parents to leave the room and leave the 2 of them in there alone. By 16 or 17, see the doctor alone. I wouldn't say for the entire visit, but think about becoming 18 and a legal adult. And then when you're 18, unless you have guardianship of your child, you have to give written permission for the clinic to talk to you. So, I mean, technically, I have to say we're sloppy about this, but technically, if you call and say, you know, my 18-year-old, vomited, and I'm not quite sure what to do, you know, technically, we have to actually have permission to talk about your 18-year-old with you. And most of the patients we've had this long-standing relationship with, and we kind of forget that. But that's really important, because otherwise, if you call and you get somebody who's on call and doesn't know you and doesn't know that long relationship you've had, they may have to tell you, I can't talk to you. And that's not satisfying. So get those things written. And then this is for the parents, and it's pretty much the same as the child. You know, help them learn, have them carry a card, encourage them to see the doctor alone for part of the visit. Look at things in insurance, help them find a doctor. It kind of just parrots what's there for the kids. So they actually have a questionnaire, and you can actually fill this out. You could actually fill this out once a year in clinic to see where you're at. I can explain my healthcare needs. I know my family medical history. I talk to the doctor instead of letting my parents talk for me. I see the doctor on my own. I know how to find the doctor's phone number. So these are stages that you go through, and you can kind of see how you're doing. And then the same thing for parents. You know, my child can do these things. It's a little harder if you have a child who has intellectual disabilities. But they actually even have a questionnaire for intellectual and developmental disabilities that's a little bit slimmed down, but I know how to fill out medical forms. I know how to ask. I know where my pharmacy is. I know what to do when I run out of medicine. Things that can kind of help them prepare for independence. So are there any transition paradigms already written? And the really kind of the big one that's written is for PKU, or phenylketonuria. Oops. And it was done in Seattle. Oh. And there's one through Boston Children's Hospital as well. So this actually they do in an 8-visit. It's a formal curriculum. You can go online, you can print it out. It's free. And it, again, asks questions. I can describe PKU to others. I can explain it. I understand how my lifestyle affects my management. I can record my food and formula. Obviously I cut it off. But these are things that you can work on. So it talks about readiness, disease management, life skills, education, and transition to adult life. 8 visits is, if it's done, it may be done over 4 years if you go to the clinic twice a year. So when I say 8 visits, I don't mean like only 8 months. It can take a while to go through all of this. Boston Children's Hospital also has a PKU toolkit where they talk about health readiness, knowing about your metabolic condition, understanding your health summary, and making a transition plan. And what I like about theirs is their questionnaire. You answer yes or no. I know my insurance. I know my basic treatment. I know how to prepare and shop for my food. But when you get to the end, you get a score. There it is. So how many of these statements can you say yes to? And as you're moving up the path, your score should go up. So what about adult independence? There's actually going to be a session here at this meeting on career choice. And it's something to think about. So, perhaps nursing is not the best career choice for somebody who's at risk for rhabdomyolysis, because nurses are on their feet all day working. But maybe speech therapist, if you want to be in a healthcare field, is a better lifestyle. Maybe if you want to be an engineer, a civil engineer who's out, surveying and doing, investigating job sites and highways all day is not the best kind of engineer to be. But maybe, the engineer who, sits and draws the plans is the better kind of engineer. So you really kind of need to think a little bit about how physical a job's going to be if you are somebody who is at risk for rhabdomyolysis. Going to college. Big colleges have long distances between classes. I went to a huge college, and sometimes if you had classes 15 minutes apart at opposite ends of the campus, you had to take a bus. So, is this campus accessible? Are the buses accessible? When I went to college 150 years ago, there was a lot of 3- and 4-story buildings with no elevators. I would hope that changed after the American with Disabilities Act, but you need to change it. You need to check it out. And I think there's actually also a session here on college. And then medical care. Most kids would rather die before they go to the school nurse, or, even in college before they'd go to the med center. And that's probably someplace you need to be familiar with. So what about living independently? How are you going to meet your medical needs? Transportation, you're going to drive? Somebody needs to drive you. Can you cook your own food? Can you manage your own money? Now, this is something people don't talk about a lot, family planning. So the metabolic disorders and the fatty acid oxidation disorders are inherited. Most of them are inherited in what we call a recessive way, meaning parents are carriers. And they have one working gene and one non-working gene, and they, by chance, 25% chance, pass that non-working gene down to both children, to the affected child. So this conference is probably not the best place to meet your potential spouse if you have a fatty acid oxidation defect. Because if you're both affected, if all you have is a gene that has this FAOD on it, that's what you're going to pass down. And if that's what your partner's going to pass down to, you're going to have affected children. If you have children with somebody from the general population with no family history of LCHAD or TFP or whatever, the chances are much lower, and a genetic counselor can talk to you about those chances. But I also want to talk about pregnancy. Pregnancy can be difficult, particularly with the fatty acid oxidation. There's a lot of throwing up that goes on early in pregnancy. You really have to talk to your providers before you become pregnant, really, about, is pregnancy safe for me? And, it used to be that we did not provide reproductive counseling in terms of genetics until people were 18, because we said they had to be, if they come in and say, I want testing for this or for my boyfriend for that, and they had to be 18 for us to do that. Oh, and then, people don't wait till they're 18 to get pregnant. So this is something you have to really start early. We live in this Harlequin romance society where, if you just, get carried in the moment one night and something bad happens, well, okay, we can understand and we don't like it. But if you say, this is the right time in my life for me to be sexually active, I'm going to be responsible, and I'm going to go and I'm going to get birth control, and I'm going to talk about pregnancy and childbirth with my doctor, well, that's bad. You can't do that. And you really have to kind of start young in today's society. Now, alcohol. It turns out that alcohol decreases your body's ability to make glucose. So does that mean you can't ever have a glass of wine with your dinner? No, it certainly means you can. Alcohol also has calories in it. It's one thing that makes it different from other substances. But you really should not go out and get stinking, vomiting drunk. Young children who have more precarious metabolism will get, frankly, even without a metabolic disease, will get, frankly, hypoglycemic when they walk around after a party and drink what's left of the beer, and the people left in the cans and in the glasses. Adults generally don't, but if you already have a fatty acid oxidation disorder, and then you drink yourself into a stupor, and then you vomit, and then you sleep for 6 or 8 hours, and then you wake up and you're still not hungry, you could get yourself in big trouble. So be judicious with alcohol. What about other substances? Well, I actually know of an MCAD patient who was on probation, and for not really a terrible offense, stuff older teens and young adults do, and got caught, and then went out and smoked a joint and failed a drug test, which ended the probation and brought him into police custody. And his mother called the police and said, "You got to feed him, you got to feed him, you got to feed him." They gave him a sandwich, but he died. So don't do things that are going to get you arrested. And also wear a medical alert bracelet, because adult medicine are used to people with diabetes, and they are not going to pump you up with glucose unless they know that they have to and that they're supposed to. And as a matter of fact, when I have to put patients in the adult hospital and we give them a high dose glucose, some internal medicine person will walk in the room and say, "What are you doing on all that glucose? Shut it off." No. So really, a medical alert device could save your life. Choosing doctors. Now, when I first moved to Pittsburgh, I have asthma, so I had to find an internist and a pulmonologist, and I fired the first two that I got, the first one of each, because they just didn't work for me. So it might take more than one try to find a doctor that you click with. Now, there's a couple of people who treat adults and children, and those are the medicine pediatrics. It's a 4-year program where you come out boarded in both adult medicine and in pediatrics, or family medicine, which is a 3-year program. And where you live and where people train depends a lot on what the emphasis in your family medicine program is. I know one program where they did 2 months of pediatrics as interns. That's not very much. So some are more peds oriented, some are more adult oriented. So you just kind of have to find out what's going on in that practice. But these are people that you could start with and stay with. You might be able to stay in your parents' insurance till you're 26, which is a Obamacare. Don't forget dental care. When you get a bacterial infection that settles in your heart valve, it's very, very difficult to treat. And most of those originate from mouth bacteria. So don't let your dental health go to pot. And have a backup plan of what you're going to do if you get sick on weekends and holidays. Because what I found with my mother when I would call on a Saturday or Sunday is they'd say, "Well, if she's that sick, take her to the emergency room. Otherwise, call her regular doctor who knows her on Monday." So you may need to have a backup plan of who you can talk to on a weekend and what you're going to do. And the adult medical care system isn't always nice to people. And you may have to advocate. You may have to kind of stand up and say, "Pay attention to me. Give me more than 6 minutes of your time." So when you're helping your teen develop their self-management skills, you really need to think about where they're coming from, what's inside their head. Their adolescent thinking, the omnipotence, the reluctance to ask for help, the need to fit in socially, the need to separate from you, and all those other burdens and tasks of adolescent. Let it be age appropriate. What you ask for your 13-year-old isn't the same thing you're going to ask for your 17-year-old. And remember that their brain growth is still going on. And that transition is a process. It's not a switch that you flip. So start early. A 5-year-old can push the button on the blender when you're making formula. When they're a little older, they can put stuff on the scale or, stir it if you get something that isn't going to tip over and spill. They can start early with even before you really think about it. So they don't have to be able to bake a cake, but maybe they can, hold the measuring cup, or you hold the cup and they pour into it. Try not to do too many things at once. Let them develop a relationship with the clinic outside of you. And that's really hard for a lot of parents to say, I'm going to step back and let you talk to the doctor alone now, because you're not going to know what was said. You're only going to know what the child said the doctor said. And, you might have to call and check up on it later. And then, it isn't fair. It isn't fair that they have to deal with this. And if you could make it fair, I know you would. I know you would trade places with them in a second. But you can't let feeling sorry for them sabotage management either. So, if you're really up against a wall, think about a therapist. Can a therapist help? Or even if there's a group in your area for kids with chronic illness. And then kids often accept things better from somebody else than their parent. So if you want to do education on how to make your formula or measure this or that, or why it's important to do something, maybe the clinic can help you. So in summary, although most metabolic care remains with a pediatric-based clinic, most of the other services your child gets will require transition to an adult provider. The lack of adult trained providers is not going to change anytime soon. We're not even training enough pediatric trained providers to keep up with what we need. The adult care world can be intimidating and less personal. And if you're one of those unfortunate people where your pediatric medical provider is not allowed to care for you as an adult, you need to work with them and make a plan. And you may need to travel to a clinic. You may need to do something else. Some transition guidelines have been published, and we need some for FAOD. And then there are some of the PKU that you could try to adapt to your needs. So keep a file, keep your child's medical records. Once they transition out of their current hospital, it may be hard to get them. By mid-teens, I would start talking about whether you need to worry about this. Give yourself enough time, because, it isn't necessarily like that. It's going to be like that. And manage your expectations to the developmental readiness. Now, I would say one more thing. If your child is not going to be able to self-manage, there is such a thing as a special needs trust. So when your child's on Medicaid, they will not be able to take cash from you. And when you die, they will not be able to inherit from you, because the money will they'll just stop their Medicaid until they'll spent and then restart them. But there are ways that you can help them. A special needs trust, they have rules about what the money can be spent on, but you can put money in a special needs trust. It can be used for clothing, extra food, low fat foods, vacations, hobbies, other ways that you can supplement the quality of life for your child. And then when you die, their inheritance can pass into that trust. So there are ways you can provide even if you're not here anymore. If you need to get guardianship, start early. Like I said, if you show up at 18 years and 1 day in the hospital, technically they can't talk to you. We usually do, because we have to do what's best for the patient, but you'll find some people who'll put their foot down. Keep a copy of all your records, but also remember social needs. So I learned a lot of things from my patients, but this one was a young man in his 20s who was just a lovely young man. But he was very handicapped and he needed a lot of help bathing and dressing. And the plan was he was going to live at home as long as his parents could take care of him. And then he was going to go live with his sister. Well, when he was in his early 20s, Dad hurt his back. Couldn't help him in and out of the tub, couldn't help him dress anymore. And so he went to a group home temporarily because sister was still too young to take him at that point. He totally blossomed. He loved it there. He got to move out and be independent, just like his siblings. He was very proud of himself. And he was bored at home. Nobody realized how bored he was at home. He had friends. This place, they go to the dollar movies every Friday night. He's a little unsteady on his feet, so they had him push somebody else's wheelchair through the mall when they went to the mall every weekend. He didn't come home again. Well, he came home every Sunday. His parents picked him up, went to church, had dinner, and after dinner, he'd be like, in the evening, he'd be like, movie night, because it was movie night at the group home. So don't forget about social needs. And sometimes the ARC or other places can help you with that. So it's a goal. Reaching adulthood without killing your child, physically or metaphorically, is a goal. And don't forget to enjoy the ride.
Behind. So what we're going to do is we'll have time for maybe 2 or 3 questions. Or if you have something that Dr. Arnold said and you'd like to kind of catapult on that, share a little bit about your experience with something that she said. We wanted to take some time and just utilize the collective wisdom in the room of parents or previous or patients that are adults now, and your thoughts about being a teen and transitioning and what that's like. So if anybody here wants to share, you can raise your hand. I'll bring you the mic.
Hey there. I just wanted to add on to about getting guardianship of your child if there's special needs. So Jake has LCHAB, but also autism. He's pretty high functioning, but I wanted to be there for him as backup. Like if somebody tried to sell him a Lamborghini and he can't see well enough to drive, I could say, if I don't sign the contract, it can be null and void, things like that. But it was a fairly lengthy process. It probably took us about a year of testing, going through neuropsych, a social worker, and a developmental pediatrician, and it all had to be done before, at around age 16 and a half to 17, we had to start that process, and it had to be finished before age 18. And we did a will and a trust and all of that at the same time. And it might have cost like maybe $2,000. If anyone's like thinking of that, just know that, as you mentioned, there is a time constraint. After 18, you can still do it, but I think it's a little more complicated. It may take longer from what I understand.
Thank you.
Sure.
Anyone else? Yeah. All right.
Thank you. I just also wanted to add, as part of trying to get your child to be their own advocate, one thing that we've tried to do is, slowly but surely getting him, to, like ask questions, even if it's just at first, like, how are you? And then kind of gradually taking ownership of it. You had also mentioned like kind of separating from the room. Also as a transition, maybe even like sitting in the back and kind of letting him take the reins, or your child. And then like as a little stepping stone, I guess.
All right. So let's give Dr. Arnold a round of applause. Thank you so much.
you.
So